So hello and welcome to this webinar on the general principles of the coding of medication errors with MedDRA. I'm Carol Ann Wilson and work as a medical officer at the MSSO and will be your instructor today. And I'm joined by my colleague Jane Knight, who has been speaking to you before. We both will take you through this webinar that will take around 2 hours. So we have plenty of time for exercises, demonstrations, of course, addressing your questions. And as Jane has already mentioned, please submit any questions you may have during the webinar through the question panel. And I will allow as much time as possible for questions both during the course and also at the end of the presentation. But please do not raise specific coding questions, as we can't help you with individual verbatim terms, but we can guide you in terms of coding principles, of course. Now let's start. Many of you will already be familiar with the content of this first slide. The development of MedDRA was adopted by ICH in the mid of the 1990s, and ICH has finally become the owner of the terminology. The MedDRA Maintenance and Support Services Organization, or short MSSO, was put in place by ICH to maintain, further develop, and distribute MedDRA on contract. And all these MSSO activities are overseen by the ICH MedDRA Steering Committee with members from industry and regulators from different regions and a member from the WHO as an observer. Please be aware of the following disclaimers and copyright notices. ICH is not only the owner of MedDRA itself, but also owns this training material. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point refers to warranty and liability issues you should be aware of, and the third bullet point is not relevant for today. Now let me provide you with an overview on what we will cover in this webinar. At first, we will explore the regulatory background for today's topic. We will then discuss definitions and terminologies for product use concepts based on the ICH guidance documents. After that, we will look into the general principles for coding of medication errors, and then apply these principles in exercises using the MedDRA browser. And we will conclude with a question and answer session as mentioned at the beginning of the session, but we will address your questions throughout the session as well. This slide now explains about the quiz questions, the polling that we will use during the webinar. The easiest way to join these activities is to scan this QR code with your smartphone, and it will bring you directly to the poll. And as soon as I activate the first question, you'll be able to see it and respond. Or alternatively, you may enter the indicated web address paulf.com into the URL bar at the top of your internet browser in your computer, tablet, or cell phone. It will then take you to a log-on screen, and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my credentials as the username, that is Carol N. Wills 584, with no spaces, and then just click join, nothing more to be entered. So I just leave this on the screen for a moment so that you can enter the required information, but if you should lose connection in between, just let us know. I can always show you the QR code again. So let's see whether terminology works. Yes, it does. I see South Africa. Hello, good morning. Saudi Arabia, India, Philippines. Many people from Europe, Turkey, Merhaba, Spain, buenos días, buongiorno to Italy. Otherwise, it's too crowded in Europe. So let's see. So welcome. Nice to meet you all. It seems to work. Thank you for joining. Now let's get started with our topic today, that is medication errors and other product use issues. And we will first look into the regulatory background because this is an important topic that is in focus of many regulatory authorities around the world. Medication errors are a truly critical and important problem in healthcare, and they are not only of great importance for the patient concerned, but also have a huge impact on healthcare costs. They represent the most frequent preventable reason for adverse events in the use of medicinal products. And since they are actually preventable, they are in the focus of regulatory authorities. Depending on countries and regions, they support the recording, coding, reporting, and evaluation of these errors in order to gain new insights into the extent and also the causes for medication errors, with the intention, of course, to develop improved strategies for their prevention, to better protect patient safety, but also to reduce healthcare costs, because the costs associated with medication errors could be much better used in other areas of the healthcare system. Requests from regulators have also led to the addition of new terms to MedDRA, together with a restructuring of the hierarchy, with the intent to better support specific coding, but also subsequent data retrieval and assessment of medication errors and other types of product use issues. And they also led to updates and amendments of the relevant points to consider documents to provide more guidance for these coding scenarios. You may think that this topic is only relevant to the post-marketing sector, but this is not the case. It is also relevant for clinical development, clinical studies, because also in clinical development, there may be labeling problems whatsoever, leading to the fact that outpatients take the wrong dose or use a wrong schedule for taking the investigational product. Any questions so far? Jane?
No questions so far, Caroline.
Okay, thank you. As mentioned already, the PTC documents have also been updated and supplemented to provide more guidance and assistance to MedDRA users on this topic. Let us first look at the MedDRA term selection points to consider document. Here the cover page of the latest version of the document. And if you look into the table of contents, you will see that the guidance for medication errors and other product use issues like misuse, abuse, addiction, plus off-label use, overdose and off-label use is quite short. This is different with the MedDRA points to consider companion document that provides more detailed information, more examples, and guidance on medication errors and the other types of product use concepts. It is a living document that is updated as needed. It is not newly released on the 1st of March of each year like the points to consider document for MedDRA term selection. And here's the cover page of the new version 3.0 released in September last year. Amendments were made to the medication error section and new examples were added. Also, a new chapter was added addressing manufacturing and quality system issues, meaning product quality issues that are caused before the medicinal products reaches the actual medication use process. In this document, you'll find much more detailed explanations and instructions. I can only highly recommend taking a close look at these chapters. They are really very helpful to better understand the terminology and classification of such events with many practical examples. So let me show you where to find these documents, just in case you don't know. So this is the MedDRA website. If you click on how to use support documentation, and here are on the top the points to consider documents. Click on the little arrow And here's the MedDRA term selection points to consider: document in different formats, PDF, with Word format, and HTML. And here's the points to consider: companion document in PDF and Word format. So this is where you can find these documents. Now, before we go into further details, we will have to familiarize ourselves with the terms that refer to medication errors and other product use errors and issues. Here the concept description for the term medication error, taken from the MedDRA browser. A medication error is any unintentional and preventable event that may result in the improper use of medication or harm to the patient while the medication is under the control of those involved in the medication use process, meaning physicians, pharmacists, nurses, patients, consumers, or their families. The second aspect that is highlighted in green is important to remember. These errors occur during product use in the medication use process, when the product is under the control of the healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers, for instance. In other words, outside of the control of the healthcare provider, patient, or consumer. And the concept description further explains that medication and other product use errors may be related to professional practice, the products themselves, and healthcare processes and systems, including prescribing, communication of orders, product labeling, product packaging and nomenclature, preparation of products and their dispensing, distribution and administration, of course, as well as related education and product monitoring. The points to consider document for MedDRA term selection contains a table in chapter 3.16 where product misuse, abuse, and addiction are addressed. The table facilitates a high-level classification of product use errors and problems, comparing misuse, abuse, and addiction with the concepts medication error and off-label use. And 3 criteria are used for this purpose. Was the deviation intentional, a conscious decision, or did it happen in error? Was it unintentional? And who has caused this incident? Who triggered it? The patient or consumer, or a healthcare professional? And did it happen in the context of the therapeutic use of the product? Yes or no? So if you look at misuse, abuse, and addiction, you see it's always intentional, triggered by the patient consumer. Misuse, abuse occur in the framework of therapeutic use, whereas the addiction has nothing to do with therapeutic use, of course. So definitions of misuse, by the way, may not always include the concept of therapeutic use. Misuse may be similar to the concept of abuse in some regions, like for instance in German-speaking countries. Just to let you know, so terminology is different depending on regions in this instance. Now, what about the other term? Medication errors, of course, are not intentional. They can be caused by the patient consumer or the healthcare professional, and again, they also occur in the framework of therapeutic use. And off-label use, the concept off-label use, is also intentional, always caused by the healthcare professional and in the framework of therapeutic use of products. Now let me illustrate these scenarios with some practical examples. Here we have Lisa, and she has stress at work. In the first scenario, the doctor prescribes 1 tablet of a sleeping pill a night to help her sleep better. But since she is still awake at 3 o'clock in the morning, she decides to take another tablet. So this is a conscious decision on her part, a deviation from the prescribed treatment regimen for therapeutic purposes. In other words, an intentional misuse of the medication, and intentional drug misuse. In the second scenario, a friend advises her to look for painkillers on the internet to calm down. She orders the medication and takes 1 tablet a day at first, but then continuously increases the dose to 4 tablets a day by now. Here we also have a conscious decision by Lisa to take these painkillers to calm down, so she deviates from the actual therapeutic indication and gradually takes too much of them. This constitutes a product abuse, here a drug abuse. In the third scenario, Lisa does not tolerate the sleeping pill. She is dazed after waking up. So the doctor prescribes her a painkiller off-label instead. Here we have a conscious decision by the doctor for therapeutic purposes, and we also know that this is an off-label use for an unapproved indication, an off-label use of the product, the medication. So when talking about off-label use, always be aware that the 3 criteria which are required for the high-level classification as off-label use have to be met. But for coding purposes, additional information is needed to finally code to an LLT under PT off-label use. Off-label use has to be explicitly mentioned in the verbatim and in the case report to be able to code this information accordingly. Why? Off-label use refers to the unapproved use of an approved drug in a specific country, and this information is not available for coders in most instances. Coders shouldn't make this decision unless off-label use is explicitly reported. Related guidance can be found in both the PTC document for MedDRA term selection and the PTC companion document. So off-label use is really a sensitive topic in the regulatory environment, and therefore this term should be used very carefully. And finally, in the fourth scenario, Lisa suffers from forgetfulness due to the stress she's experiencing at her workplace. She also forgets that she has already taken her medication one day and takes it a second time. So this is unintentional but happens in the context of therapeutic use. This scenario represents a medication error. The following flowchart visualizes this decision-making process. Here are the 3 core questions: intentional or unintentional, caused by whom, and in the context of therapeutic use, yes or no. Let us assume that the unapproved product use took place intentionally. This may be decided by healthcare professionals or by patient consumers. If this is a conscious decision by the healthcare professional and for therapeutic purposes, we classify these events as off-label use. So these 3 criteria are required for the high-level classification as an off-label use. But again, please be aware that additional information is needed to finally code to an LLT under PT off-label use. Off-label use terms should only be selected when off-label use is specifically mentioned in the reported verbatim information in the case. If an intentional deviation from the product information originates from the patient or consumer and happens in the therapeutic setting, we classify this as an intentional product misuse. If the deviation does not occur in the context of therapeutic use of the product, the deviation is classified as drug abuse or drug addiction dependence. If the unapproved product use is unintentional, accidental, this can also be caused by both the healthcare professionals or patient consumers. If this occurs in the context of the therapeutic use of the relevant product, it is classified as a medication or product use error. Please be aware that we are looking at broad concepts in this decision chart, we are not looking at MedDRA terms that should be selected. Of course, one should only assign LLT medication error when no more specific information is available in the report. If you have more specific information about the medication error, you'll find many very specific terms in MedDRA that do not only capture the accidental nature of the incident, but also more details like accidental dose deviations, accidental schedule deviations, etc., etc. So this is just a rough chart in order to roughly classify these incidents. It's not a coding recommendation, of course. There are many more very specific terms in MedDRA for these different concepts. You may now argue that in many cases it is not clear whether such a deviation was intended or unintended. Here you can see an example for such a scenario. It is reported that the patient took an extra tablet before going to bed. If no further information is available, we do not know the background. Did the patient misunderstand the doctor's instructions or the package leaflet? This would then represent a medication error. Or did the doctor mistakenly give her the wrong schedule with a prescription? This would also represent a medication error, in this instance, a prescribing error. Or is the patient's discomfort getting worse at bedtime, and so she decided to take one more tablet? This scenario would constitute an intentional drug misuse. Or did the doctor decide to use the drug off-label because he was convinced that the treatment would be more effective this way? Our case information does not allow for any of these classifications. So what can be done when getting similar reports for coding purposes and when no further information can be obtained? Now, for coding such scenarios, MedDRA contains very vague, non-specific PTs. If it is not clear whether such an event happened by mistake or intentionally, a suitable LLT under the PT product use issue can be used, a very general term. And if it is not clear whether an intentional deviation from proper product use happens for therapeutic reasons, a suitable LLT under the PT intentional product use issue can be selected. So the flowchart shown before must therefore be expanded with these two neutral, more general concepts shown before. You can see the question marks here in our chart. If it cannot be clarified whether an intentional deviation from the label by the patient happens for therapeutic reasons or not, the incident should be classified as intentional product use issue. And if it cannot be clarified whether an unapproved product use by an HCP or patient consumer occurred by mistake or intentionally, the incident should be classified as product use issue, a very broad concept. Again, please be aware that there are more specific LLTs and PTs for these high-level concepts, so more descriptive MedDRA terms that do not distinguish between intentionality are, so to say, neutral. And you will see some of these terms on the next slide. These neutral terms do not contain the information accidental or intentional, and here are some of them highlighted. Extra dose administered, inappropriate schedule of product administration, incorrect dosage administered, incorrect dose administered, product administered to patient of inappropriate age, product administration interrupted, or product dose omission issue, for instance. So neutral terms that can be used. Any questions so far, Jane?
No, Carol Ann, there's no question so far.
Thank you. So, in order to search and select suitable MedDRA terms for verbatims that relate to unapproved product use, so deviation from the approved product information, the label, it is relevant to understand MedDRA structure and rules and the details of the points to consider guidance documents. But it is also important to make yourself familiar with the MSSO MedDRA browsing tools or your own in-house MedDRA browsers. And I will now use the new web-based browser of the MSSO to show you where to find the relevant terms and make you familiar with their hierarchy. So this is the new browser interface. Now let me switch screens. Here is the log on screen with my credentials. If I say log in, the browser opens. If you're familiar with the legacy web-based browser that the MSSO offers, you will see that the interface looks different. But I can tell you that all functionalities of the legacy web-based browser are included in this new browsing tool. So it has the same functionalities, but it looks different. The interface looks different because we saw that in most instances, the browser is used for searching MedDRA, and that's why we wanted to have a more suitable interface that is not as busy as with the legacy web-based browser. So here we are. And now I would like to show you the hierarchy. We start in SOC injury, poisoning, and procedural complications. And if I click on the plus sign, I see the HLGTs underneath. And here we have the medication errors and other product use errors and issues. If I open this HLGT, we see the HLTs. First of all, we have the accidental exposures to product included in this HLGT, and then we start with the medication errors, product use errors and issues, NEC, not elsewhere classified. So quite a number of terms in there, and also the product use issue is there. We discussed it before, so this very vague neutral term. And you will see that under product use issue, of course, you have very specific terms for duration deviations, route, inappropriate site, population, whatsoever. So very specific LLTs underneath. Let me close this HLT. And then we see other HLTs, and we see that the terms are grouped based on the stage where the error occurred. Administration stage, then confusion errors and issues, dispensing errors and issues, monitoring, preparation, prescribing, selection, storage errors, transcribing errors, and communication issues. And if I click on this HLT, you see the granularity of MedDRA in this regard. So it's really important to make yourself familiar with the different medical concepts here in order to be able to clearly distinguish these different concepts. And for that, it is really helpful. And here we have the concept descriptions, the MedDRA concept descriptions. If I click on it, you can see that they are grouped in alphabetical order. These are not medical definitions. Concept descriptions means that it's an explanation of the respective term, how it is interpreted and classified in MedDRA. You see abuse, you see addiction, then you see other chronic, acute, contributing factor. What about dose? A quantity to be administered at one time, such as a specified amount of medication. So dose always refers to the single dose, whereas dosage refers to the determination and regulation of the size, frequency and number of doses, so the duration of treatment. So it's a combination term that relates to not only the dose, single dose, but also the schedule and the duration of treatment. What is a dose omission? Refers to an event where an ordered dose is not administered before the next scheduled dose, if any. And high blood pressure, let me look to see label drug disease interaction medication errors, very specific terms. So if you are not familiar with the nomenclature, it's really important to look into these, and very helpful to look into these concept descriptions. This is the definition for medication error, the concept description here, and monitoring error, misuse again. What about overdose? For the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose, either in quantity or concentration, in other words, an excessive dose. So that's the concept descriptions for overdose. And what about underdose? For the purposes of term selection and analysis of MedDRA-coded data, underdose is the administration of less than the minimum recommended dose in quantity and or concentration. So very helpful to really look into these concept descriptions. Okay, this was the medication errors and other product use errors and issues, HLGT. And then we have the HLGT off-label uses and intentional product misuses, use issues. Here you have an HLT for the intentional product misuses caused by the patient, of course, intentional product use issues where it's not clear whether the deviation was for therapeutic purposes, and here the off-label uses. Off-label use of device, and under the respective PT, you have very specific LLTs in order to capture the specifics of the error made, or in this instance, the off-label use that was made. And then here, overdoses and underdoses, NEC. Here we have the intentional overdose, overdose, prescribed overdose, radiation overdose, and same for the underdose. Now, what about the drug addiction? For drug addiction, you have to go into the psychiatric disorders system organ class, and here to the psychiatric and behavioral symptoms, NEC. I hope that I'm on the correct path here. Psychiatry, yes, substance. Now, here we are, psychiatric disorders, here we are. Substance-related and addictive disorders, here we are. And here we have the drug abuse, drug dependence, very specific ones, antepartum, postpartum, drug use disorders. So very specific terms for these concepts as well. These you can find in psychiatric, in the psychiatric SOC. With this, let me switch back to my slides. Here again, a reminder of what we have just seen in the browser, the MedDRA concept descriptions, and the hierarchy of the relevant terms here in the injury SOC and in psychiatric disorders. Now, what kind of terms can we find under an HLGT medication errors and other product use errors and problems? We can find PTs for certain types of errors, such as wrong dose, wrong drug, wrong route, and terms that link an error to a stage in the medication use process, such as the prescribing stage here. Other terms combine the type of error with a stage in the medication use process, so combination terms. Some reside under a more general PT, others are represented on PT level, as you can see in this example here. Wrong drug prescribed is grouped under PT product prescribing error, whereas wrong drug administered is grouped under PT wrong product administered. In addition, there are terms for intercepted errors prevented by third-party intervention so that they didn't reach the patient. MedDRA also contains two PTs that describe the possibility of an error or signal a circumstance that could potentially lead to a medical device use error or medication error. And as well as more vague terms, we talked about them already, which can be used when it is unclear whether the reported incident was due to an error or happened intentionally. You can see that the LLTs linked to medication error PTs are often more than just synonymous terms. They often contain more specific information. For example, PTs for errors reflecting a stage of the medication use process may contain LLTs for specific types of errors occurring within that stage. So always search for the most specific LLT when coding to capture the full information of what has been reported. Like always, this is a general MedDRA rule. It also applies for medication errors. So now it's your turn again. Based on what you've just heard, how would you code this reported incident? Dose taken was below the minimum recommended dose in the product label. Can we consider this an underdose? Remember the concept description for underdose that we just saw in the MedDRA browser. Which LLT would you select for this verbatim? Underdose, drug administration error, accidental underdose, or incorrect dosage administered? What would you do? I see you voting. Let's see what you're going for. Underdose. Underdose seems to be the preferred option here. So accidental underdose, accidental is not reported. So we just know that the dose taken was below the minimum recommended dose in the product label. We don't know whether it was intentional or accidental. So accidental underdose would be incorrect. Drug administration error would be just too vague. And incorrect dosage administered. Remember, dosage refers not only to the single dose, but also to the schedule and duration of drug administration. So it's a combination term. Here it's just the dose that is mentioned. So underdose is the correct answer here. So well done. Thank you. Most of you voted for underdose. So this is correct. And remember the concept description. It was underdose is the administration of less than the minimum recommended dose in quantity and or concentration. So this is exactly what has been reported here. Next one. Inadvertently took excessive dose of the prescribed pills. Incorrect dose administered, overdose, accidental dose increase, or accidental overdose. Which of these LLTs would you select? Again, remember the concept description for overdose. Incorrect dose administered, overdose, accidental dose increase, or accidental overdose. So here we know that it was inadvertent, so accidentally the patient took an excessive dose of the prescribed pills. Accidental overdose. Excessive dose, this is exactly the wording in the concept description. So it's not just an accidental dose increase, but an excessive dose is considered an overdose based on the concept description. So most of you got it right here again. The correct code assignment would be accidental overdose based on the concept description. So always consult the concept descriptions if when you're not sure how to distinguish related concepts like overdose or increased dose, etc. Questions so far, Jane, before continuing?
Yes, we do have some questions, Carol Ann. Can the dosage, no, don't worry about that one. An incorrect dose administered due to incorrect splitting of tablet, would this be considered misuse?
Misuse? It could be accidental as well. So misuse would mean it is intentional. If it's because the patient is not able to swallow the tablet as whole tablet and therefore splits it, so then it would be an intentional deviation, then it would be intentional misuse, and you would also have to code that the tablet was split incorrectly because it should not be split. So if it can be split, it's not an incident at all. So it really depends on the circumstances.
And then if the patient doesn't take the full dose because of unavailability, would this be coded as misuse, was the question.
No, if a drug is not available, we had that during the corona pandemic, for instance. If something is not available in the pharmacy or the patient run out of medication for any reasons, this is not an error. So it's not under his control or her control. There are separate codes for such circumstances. Unavailability of medication, for instance.
Then we had just a simple one. What does NEC stand for? NEC.
NEC stands for not elsewhere classified. These are miscellaneous groupings of terms that do not fit into any other HLT or HLGT.
And then we had one about the definition of an overdose. What, if you can just repeat for us, what's the definition of an overdose for coding purposes?
So I can show you. Best to show you. Here we have our concept descriptions. And if I click on the O, we will be brought there. For the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose in quantity and or concentration. In other words, an excessive dose. That's the concept. Any further questions?
No, that's all the questions we've got so far, Carol Ann. Yes,
Thank you,
that's all
Jane.
the questions. Well, thank you.
So then we have now made ourselves familiar with the classification of medication errors and other types of product use issues. Now let's have a look at some general principles for coding of medication errors. First, a short reminder regarding the basic rules to be followed for coding with MedDRA. The quality of the reported information and the extraction of the relevant information during data entry are a basic requirement for good and meaningful coding. If the information received is vague or ambiguous, of poor quality, ask for clarification. Coding is done on the LLT level, and the LLT that most accurately, most specifically reflects the reported incidents and events should always be selected. Nothing should be interpreted, added, and no relevant information should be omitted. This is the basic MedDRA coding rule, code as reported. And of course, only current LLTs should be used for coding. So I assume that you are all very familiar with these basic rules, so I will not go into this any further. For coding product use errors and problems, the following tips may be helpful. First and foremost, you should be familiar with the MedDRA concept descriptions and the points to consider guidances. like the points to consider document for MedDRA term selection and the companion document, so that you know where to find more detailed information, more guidance in order to achieve accurate and consistent coding. You should also have good knowledge of the MedDRA structure and hierarchy, particularly in SOC injury, poisoning, and procedural complications. Once you have found a potentially appropriate LLT and PT for the reported incident, check if the placement of the selected LLT and PT accurately reflects the reported event. This is also a general coding rule for MedDRA. Always check the hierarchy to reassure yourself that you are on the correct track, that the selected concept really represents what has been reported. It is best to search the MedDRA hierarchy top-down when coding medication errors and other product use concepts, unless you are already very experienced in coding such incidents. And finally, if you can't find a specific term for medicines, vaccines, or medical devices, look out for a product term that would be suitable for your coding tasks. The companion document specifies some principles for coding medication and other product use errors. When to use the PT medication error, when to select more than one term, when to use the PT off-label use, how to capture potential and intercepted medication errors, how to capture both the specific type of error and the stage of the medication use process where the error occurred, when to capture the contributing factor or factors leading to medication errors, that we should not infer a medication error when it's not reported, and also capture medication errors related to products with a drug delivery device. This section in the points to consider companion document was rewritten and amended. It was previously titled Device Use Errors, Wrong Technique, and Device Malfunction. So if you are interested in these products because they are relevant for your company and your coding tasks, take a look at this section, as today I will not be able to cover all details. We will now address these general principles one by one. The first principle refers to the use of PT medication error. As coders, we should not use this term unless we have no further information reported in the case. If you have further information, then search the hierarchy under HLGT medication errors and other product use errors and issues and select the most specific LLT that you can find. And if a specific error is reported, but no suitable term can be found, then please submit a change request to get a better term and assign the LLT that best represents the reported concept, so the best approximation to the reported incident as a placeholder. Here an example: if it is only reported that a patient inadvertently didn't use the medication as prescribed and no further information is available, then of course LLT medication error can be selected, which is grouped under the same PT. Sometimes you will get a report of a chain of events where an initial error leads to additional consequent errors or even adverse events in the patient. Then code the initial error, the originating error, as the priority. And all consequent errors in the medication use process and adverse events have to be coded in addition as reported. So if a prescribing error for the wrong drug is reported that consequently resulted in the wrong drug being dispensed and administered, the full information should be coded by assigning LLT wrong drug prescribed plus LLT wrong drug dispensed plus LLT wrong drug administered to capture these consequent errors. And do not forget to also capture the contributing factors that led to this chain of events if reported. We will discuss these contributing factors in more detail in a moment. But on the other side, avoid double coding the same error when this does not add any information. Again, an example for this principle, it is reported that a nurse miscalculated the dose and the patient received 40 milligram instead of 20 milligram of his medication. He experienced severe hypotension. We would capture the initial error with the LLT dose calculation error, plus the resulting administration error with the LLT increased dose administered, same PT. And of course, we would also capture the resulting adverse event in the patient with the LLT hypotension. It is a chain of events starting with the dose calculation error that leads to the administration of an incorrect dose and finally to an adverse reaction in the patient, a hypotension. Are there questions so far, Jane?
Yes, we've had one additional question, Caroline, about the definition of when you would use therapy interrupted versus missed dose. So do you want to take that one now?
I will take it. Just remind me if I forget. If I'm in the browser, then I can show it. Yeah, in
Okay.
the hierarchy. Yeah, good
Yes.
question.
Okay.
Thank you.
We've got a question related to that.
Yeah.
And then we've got another one about overdose. Is overdose to be chosen when the dose administered is not above the maximum allowed dose per day?
No, then it's just an increased dose. When it's still within the therapeutic range of the product, it's an increased dose, but it's not an overdose.
And
Overdose
if
is
it's
only when it exceeds the therapeutic range of a product, so the defined margin, so to say, um, of what is defined in the label.
okay, and then we've got one which is very specific. I think we'll have to look at that one. Okay, carry on, Caroline. Thank you.
Good. The next principle refers to off-label use. Always consider the criteria and information required to select a term under the PT off-label use. Off-label use relates to situations where a healthcare professional intentionally prescribes, dispenses, or recommends a product for a medical purpose not in accordance with the authorized product information. It has to be an HCP, it has to be intentional, and for a medical purpose in the context of therapeutic use. So these are the criteria that must be met for the high-level classification. The highlighted sentences were added to the meta-term selection points to consider document that were released in March 23 and 24, and related guidance can also be found in the points to consider companion document. As a coder, off-label use terms should only be selected when off-label use is specifically mentioned in the reported verbatim information. Coders should not take this decision when only the three criteria intentional for medical purposes by HCP are met, because it needs more specific product knowledge and information about the country of origin of the reported case. Local regulations and the product information may differ between regulatory regions, so try to obtain clarification, but if no further information can be obtained, do not infer that off-label use occurred. Regulators are very clear on this, and you'll see that in all examples of off-label use in the points to consider documents, the off-label use is clearly named in the wording. Let us look at an example. It is reported that a pediatrician decided to use COVID-19 vaccine off-label for his 10-year-old high-risk patient, although not yet approved for this age group. Does this verbatim fulfill the criteria for classification as off-label use? And is off-label use explicitly mentioned? So HCP has caused the deviation. It was a pediatrician. He did it intentionally. He decided to do so, and based on therapeutic considerations. Because he wanted to protect his 10-year-old patient from an infection. And we are told that he decided to use the COVID-19 vaccine off-label, meaning that the vaccine is approved for immunization against COVID-19 infection in the respective country, but not for this age group. So the most specific LLT for this scenario is LLT off-label use in unapproved age group under PT off-label use. Are there questions, Jane?
No, no, Caroline, not for now.
Okay. Principle number 4 refers to potential medication errors. Such incidents should also be captured, and MedDRA has 2 PTs for doing so. PT circumstance or information capable of leading to medication error, and PT circumstance or information capable of leading to device use error. The type of the potential error always needs to be captured in addition, and the circumstance or information capable of leading to medication errors groups several specific LLTs for doing so, like LLT potential for medication error, wrong dose, or LLT potential for medication error, wrong drug, and LLT potential for medication error, wrong route, or the newly added LLT database system product information issue. In addition, MedDRA terms that help capturing the contributing factors should also be selected, like for instance LLT drug label lookalike. Why do some regulators want to receive this information, are actually very keen to receive such information? You may consider this an overkill, but in such scenarios, no medication error happened yet, but could of course occur in the near future based on the reported contributing factors like drug name confusion, etc. When understanding the background for these potential errors, regulators can take steps to prevent these errors even before happening. So depending on your local regulatory requirements, do not omit such information, but capture all relevant information when receiving similar verbatims. Encode both the potential for an error by selecting an appropriate LLT under one of these PTs. And if a specific potential error type is reported and no combination term is available, split code. And last but not least, do not forget to also code the contributing factor or factors when reported. Here again an example for this principle. A pharmacist reported that the blurred print on the drug label could lead to a medication error, that a wrong dose could be administered. No medication error occurred yet, but the pharmacist saw a circumstance, the blurred print on the label, that could lead to this error in the future. So remember, we would code the potential error by selecting LLT potential for medication error, wrong dose, under PT circumstance or information capable of leading to medication error. A perfect combination term that captures the potential for a medication error and the type of error. If no such term would be available, split coding would become necessary, and the type of the potential error would have to be captured in addition by assigning LLTs like wrong patient or wrong schedule or wrong rate, for instance. And We would also code the contributing factor that could lead to this medication error, here the blurred print on the label, by selecting LLT product label text illegible under PT product label issue. Are there questions, Jane?
No, I don't think, no, Caroline. No, sorry,
Okay.
I'm just looking through them all. Oh, hold on, here's one just arrived. An eye drop was prescribed to a patient. Oh, this is too specific. I'll come back to it, Caroline.
Okay. Next principle. Sometimes medication errors at an earlier stage of the medication use process are prevented from reaching the patient or consumer. So a medication error occurred during prescription, preparation of the medication, etc., but is detected and intercepted by an active intervention of another person. When such scenarios are reported, the selected term for the intercepted error should represent the stage where the error actually occurred, not where it was prevented. Meaning that when it is reported that a pharmacist made a mistake when dispensing the drug, but the nurse identified the error before giving the drug to the patient, we should select LLT intercepted drug dispensing error under PT intercepted product dispensing error, capturing the stage where the error actually occurred. We would not code to LLT intercepted administration error because the nurse did nothing wrong. The error occurred at the dispensing stage. New questions, Jane?
No, Caroline.
Okay. We already talked about the stages of the medication use process when looking into the HLGT medication errors and other product use errors and issues and the MedDRA hierarchy underneath. The slide shows the different stages, starting with the storage of the medication, continuing with the prescribing stage, transcribing stage, the preparation, dispensing stage, the administration stage, and finally the monitoring stage. One of the principal MedDRA coding rules, code as specifically as possible, capturing the full information of what has been reported, also applies to coding of medication errors, meaning that if a specific error is reported that occurred at a specific stage of the medication use process, we should capture the full information, the type of error, and the stage where it occurred. You'll see that MedDRA contains many terms that capture both the type of error and the stage, like for instance LLT wrong drug prescribed. Others only capture the type of error, like LLT wrong drug or LLT wrong dose. So if the stage where the error occurred is unknown, you can just select the LLTs for the type of error. And others capture the stage only, like LLT drug prescribing error or LLT drug dispensing error. Again, if the error is not specified, you would just select an LLT to capture the stage where the error occurred. So always capture both the stage and the type of error where it is known. And if the stage is not known, capture the type of error only, or if the type of error is unknown, capture the stage only. When both the stage and the type of error are reported, you would look for a combination term in MedDRA and use a single LLT to capture the full information, when possible. As shown in the first example, when it is reported that the pharmacy dispensed the wrong drug, the LLT wrong drug dispensed would capture the full information. There is no need to assign two codes like LLT wrong drug and LLT drug dispensing error. This is an example for what I have mentioned before. Only use split coding when there is no single LLT which captures all of the reported information. Do not split code if splitting does not provide relevant additional information. But sometimes you may not find a suitable term, a suitable combination term. If it is reported that the doctor mistakenly prescribed the wrong strength, you would have to split to capture the reported information in full by assigning LLT wrong strength and LLT drug prescribing error. Let me interrupt again, just to not miss any questions.
We've got some questions, but they're not specifically related to what you're doing now.
Okay.
One of them is a general question that often medication errors don't have direct consequences to the patient. For example, labeling errors that lead to misuse. So I don't know if this is labeling as in label like a quality issue in the label or what, but leading to misuse. Should these reports be accepted?
I think everything that could lead to a medication error should be captured. It really depends on the regulatory requirements in your region. So it really depends on the regulatory requirements. But I know that many regulators really want this information, not as a case report, so as an ICSR in post marketing, but in summary reports.
And then we've had one that if the patient finds the bottle difficult to open, and so they use it wrongly because they're afraid that they can't close it, or they don't like the mechanism of a bottle, for example, opening it, but through fear, and they use it wrongly or they miss doses, how would you code that?
We will see such an example in a minute.
Okay.
Yeah. Okay,
Yep.
good. Then I continue. We already shortly addressed the contributing factors when talking about potential medication errors. The new version of the companion document provides a MedDRA concept description for contributing factor. It is a circumstance, action, or influence which is thought to have played a part in the origin or development of a medication error or to increase the risk of a medication error. If a medication error is reported in conjunction with an actual cause of this error, then always select a term for the contributing factor plus the resulting error. Remember what we discussed earlier. Contributing factors are critical to understand why an error occurred and to identify interventions that can be undertaken to prevent the error. And that is why many regulatory authorities are very interested in obtaining such information about these contributing factors. But of course, there are contributing factors which are not in the scope of MedDRA. As an example, organizational system issues such as noise level, fatigue, and staffing levels may contribute to medication errors, but these factors may not have specific MedDRA terms. Such scenarios can be coded to an overarching term, like for instance LLT, organizational systems issue contributing factor, and the specific organizational system issues should be recorded in free text, that is, in the narrative section of the case report. The next example describes such a case. A doctor wrote a prescription for 40 milligram of drug X for angina every 6 hours. But because of the illegibility here of the prescription, the nurse administered the same dose of drug Y, a calcium channel blocker used in the treatment of hypertension, for which the maximum daily dose is only 10 milligram. So because of the error made, the patient received 160 milligram of this calcium channel blocker per day. Excuse me. 4 times 40 milligram. And a day after taking the first 4 overdoses of the calcium channel blocker, the patient suffered a heart attack and died. So what needs to be captured here? At first, the illegible written prescription. the resulting medication errors, the administration of the wrong drug, and the accidental overdose of the drug, and the resulting adverse reaction in the patient, the heart attack. Remember, it is very important to capture the contributing factor or factors if reported. And of course, also the indication for use, the angina pectoris, would have to be coded as well. Questions, Jane?
No, Caroline, nothing new. No, nothing new.
Okay, then the next one is it's an important principle as to not infer a medication error. So remember another basic rule for coding with MedDRA: code as reported, do not add or subtract relevant information. The same rule also applies to the coding of medication errors. If you receive a verbatim that describes a deviation from the label, an unauthorized use of the product, only select an LLT or LLTs that reflect what has been reported. Do not assume that a medication or device use error occurred if this is not made clear in the verbatim in the case narrative. If it is reported that a nurse administered 50 milligrams of drug X, do not assume that this is a medication error. Try to obtain more information from the reporter or find out the dose range referencing the prescribing information of the respective drug. So do not assume that this represents a medication error. Now we come to the question that was raised for the device, drug delivery device. The next slide shows the last principle that we will discuss today: how to capture medication errors related to products with a drug delivery device. An increasing number of marketed products are intended for use with a drug delivery device, like a drug-device combination product, or co-packaged in a kit, or separately distributed but labeled for use with a specific device. Similar to what we already discussed for medications, safety reports for these products may relate to medication errors, to complications when using the device, like for instance needle stick injuries, or to product quality issues as well as consequent adverse events in the patient. And as always, in case of incomplete or ambiguous reports, clarification should be sought to clarify whether the incident is related to a device issue or malfunction or a device use error by the patient. Let's look at an example taken from the new version of the Points to Consider companion document. It is reported that due to a new design, a pen was difficult to activate. A patient pushed the plunger button as hard as he could, but managed to deliver only a partial dose. The device quality issue, the new design, led to the problems when the patient was using the pen. Both needs to be captured, the device quality issue and the device use issue. It is a chain of events. The device quality issue is a contributing factor to the fact that the patient has difficulties using it. So we would assign product design issue, same PT. This PT is grouped under SOC product issues and HLT product quality issues NEC. In addition, we would select LLT delivery device component difficult to use under PT device difficult to use that resides under SOC injury, poisoning, and procedural complications and HLT medication errors, product use errors, and issues NEC. And we also have to capture the consequent medication error by assigning LLT partial dose delivery by device under incorrect dose administered by device. It is a chain of events, and split coding is required to capture all reported information. So I hope this could answer the previous question.
Let me give you the question, Caroline. So the scenario is an eye drops. The bottle is difficult to open. The patient finds it difficult to open. Therefore, the patient leaves the bottle open because she's afraid that if she closes it, she won't get it open again.
Yeah, it's
As
the
a
wrong thing.
result, she
Yeah,
misses doses.
as a result, she misses doses.
Misses
Okay.
doses and she leaves it open.
So it's the drug. It's the container is difficult to use. The close. We would have to search really in product issues. So obviously the container is difficult to open. There are specific terms in MedDRA for such a scenario. It's the product quality issues, leading to the fact that the patient has difficulties handling the container of the medication and leaves it open. This is a wrong technique in the use process. And then, of course, you would also need to capture the fact that she misses doses.
Thank you, Caroline. We've had a couple of questions about overdoses again. Okay, I'll let you carry on. If we've got time at the end, we can come back to them. Some of them are
Yeah.
very specific.
Okay. So in the last part of this webinar, we will now work together on 5 examples as demonstrations. We will use the previously introduced decision chart and also apply the general principles for coding medication errors and other product use concepts that we have just discussed. At first, you will have to assess the reported information, always. First, check for the 3 criteria for the classification. Did the incident occur intentionally or unintentionally? Who has caused it? Was there a therapeutic purpose? Did it happen in the context of therapeutic use of the product? Then check at which stage the error occurred and whether it led to consequent errors and even harm in the patient. If contributing factors are reported, they need to be captured in addition. Or was the report referring to circumstances that could lead to a medication error? Or was the error intercepted before reaching the patient? Because the type of report, the type of information that you get will influence the way you search for appropriate terms. It will help you find the most suitable LLTs, so the closest matches. Here our first example. It is reported that the nurse forgot to administer the second of 2 chemotherapy treatments to the patient. So what can we take from this report? Is it reported whether it was accidental or intentional? Yes, we know that the incident happened accidentally. The nurse forgot. Do we know who caused it? Yes, an HCP, a nurse. And was it in the framework of therapeutic use of the product? Yes, it was. We also know the stage where the error occurred, but there is no information about a contributing factor. So this was not provided. Now, how would you approach this report? Which LLT would you select? Nurse forgot to administer the second dose of chemotherapy to the patient. Scheduled daily dosing taken less frequently, drug dose omission in error, drug use for unapproved schedule, temporary interruption of therapy. What would you do? See you voting. Let's have a look what you're going for. Some are considering that this is a schedule issue. Drug dose omission is one option. Drug dose omission in error. Majority are voting for this one. drug use for unapproved schedule, and others also would consider temporary interruption of therapy. But most of you are voting for drug dose omission in error, and this is correct. So let's see what our decision chart says. Let us use it. We know that the incident occurred in error. The nurse forgot. We know that it was caused by the nurse, an HCP, and we know that it occurred in the framework of therapeutic use. So the incident has to be classified as medication error. Now let's have a look into the MedDRA browser to find the best term again. Let me switch to the browser. So let's look into the injury SOC again. Let me collapse all here. Injury SOC, here we are. And we go to the HLGT medication errors and other product use issues. Here we are. So nurse forgot to administer the second of 2 chemotherapy treatments to the patient. So it was one treatment that was missed in error. So it's a drug administration error. And there is a drug dose omission that does drug dose omission. Here it is, drug dose omission by device. Here's the product dose omission issued, product dose omission in error. We know it was inadvertently, so it was an error. Let us look into this PT. Drug dose omission in error. That would be the best, closest LLT that we can find for the reported incident. So you can see that there is also this issue term. So when it's not clear that it was an error, or when it's not clear that it was an intentional drug dose omission, then you could use one of the LLTs underneath this PT. Now, what about the inappropriate schedule of product administration? Let us look into inappropriate schedule of product administration. Here we are. So we see drug dose administration interval too short, once monthly dose taken more frequently, less frequently. So these are these should be selected when it is reported that dose omissions occur regularly, take place more often, like when a patient takes a once daily dose less frequently or more frequently. So this is not a schedule issue that was reported here. If I look for drug use for unapproved schedule, drug use for unapproved schedule, here it is, and I right mouse click, go to browser, it will show the term in the hierarchy. Here it is. It's grouped under product use issue, so a very vague term. So that would not be appropriate because we know that it was an accidental dose omission. So drug use for unapproved schedule would be inappropriate. And now we come to therapy interruption, and this was the question we have received before. If I look for therapy interruption, therapy interrupted, go to browser. Here it is, temporary interruption of therapy, therapy interrupted, same PT. You will see that we are in a completely different system organ class now, because, now let me open details and occurrences. You see that we are in the surgical SOC. It's considered a therapeutic procedure. It's a therapeutic decision to interrupt the therapy. Maybe before a surgery, anticoagulants are anticoagulant therapy is interrupted because of the bleeding risk. So such decisions do not represent a medication error or an intentional use issue, but that's a medical decision, conscious decision, and this is not to be considered an error or use issue.
So,
I hope.
Caroline, let me read you the question because you've raised a grey area here then. The patient missed some doses due to being admitted at the hospital. So it hasn't specified that it was advice by the hospital staff to stop the therapy. But the question is, should this be missed dose or therapy interrupted? To me, it still looks more like a missed dose. But what do you think?
Yeah.
The patient missed
Yes.
some doses due to being admitted at the hospital.
Yeah, I would assume that usually in the hospital you are asked what type of medication you are taking, and you should be continuing taking your routine medication. So if the patient did not take the medication as usual, then maybe forgot to bring it to the hospital or to tell healthcare professionals that this would be needed. So this rather sounds like a medication error. But
It does.
it really
So
depends on the. It's a very specific question. You need more
thank you.
information in order to be fully clear about the scenario.
It hasn't specified interruption, so I would
Yeah,
take it as dose
yeah,
missed. We've
yeah,
got some others, but some of them are very specific, some of these. So we have some questions if you've got time at the end. Can you also show us that when you're in the browser at some point, can you show us some of the neutral terms when it's not known whether a patient, whether it is an error, we don't know if it's intentional, we don't know if it's by the patient, we just know that something's been taken outside of the labeled guidance, the labeled recommendation.
So let's take the administration errors then. So incorrect product formulation administered, incorrect drug administration rate. So this does not contain the information accidental. Incorrect dose administered, wrong dose administered. So here we are.
Thank you. Just coding what's been done rather than
Yeah,
assuming it's
yeah,
intentional or not. Then we've had a question about interruption of administration. So, for example, if it's an infusion and it becomes blocked and they replace it, so they stop it so they can replace the line, that
yeah.
would be product administration interruption. That would be correct. That's different from interruption of therapy, isn't it?
Yes, yeah. Here it is, product administration interrupted. This is referring to such a scenario.
Thank
Infusion administration interrupted, for instance. Yep.
Let me just go back to the list of questions. So that seems to be we've had one about a drug taken for an abortion, induced abortion. But as I say in the scenario, it's very specific. It doesn't specify whether it was intentional or not. So the
Yeah.
drug being taken, you would just you'd have to choose a neutral term.
Yeah, it may be too confusing if we address such specific scenario. It may be really confusing for the rest of the audience. So if you have terms that you would think are relevant for a wider user community, then submit them to the help desk, MSSO help desk, and Jane and I may consider it for the Let's Code Together sessions that we provide. It's more workshop formats, webinar, where we address such specific scenarios.
Thank you, Caroline. Carry on, just in the interest of
Mhm.
time.
Yes. So here we are. This is a reminder of what we just saw. And the correct term selection is drug dose omission in error under PT product dose omission in error. Most of you voted for this term, so well done. Next one. Here it is reported that the patient did not read the instructions thoroughly and then took his drug twice a day and not just once a day for the prescribed 2 weeks. So what do we know based on the information provided? Is it reported whether it was accidental or intentional? Yes, we know that the incident happened accidentally. The patient did not read the instructions thoroughly enough. That's why he got confused. Do we know who caused it? Yes, the patient. And was it in the framework of therapeutic use of the product? Yes, it was. We also know the stage where the error occurred. The drug was administered, but no contributing factor was reported. So we know that the patient didn't read the instructions thoroughly, but we don't know why, whether he was under stress, distracted, whatsoever. So how would you approach this reported incident? Would you select LLT drug administration error, extra dose administered, once daily dose taken more frequently, increased dose administered, incorrect dose drug administration duration, or product leaflet instructions confusion? And more than one term may be necessary to select in this instance. So let's see what you're going for. Oh, we have split of opinions here. Drug administration error, once daily dose taken more frequently, seem to be the most frequently selected. Product leaflet instructions confusion as well. So let's see what we have. Let's use our decision chart again to classify the incident. We know that the incident happened accidentally. We know that it was caused by the patient. And we know that it was in the context of therapeutic use, meaning that this verbatim describes a medication error. So now let me again search for the most specific terms in the browser. Let's search together. So I will use the search function in this instance. We had one option, drug administration error. Oops, spelling error. Here is the drug administration error. Go to browser. Again, we see the term. It is under the HLT product administration errors and issues, but of course it is a very vague term. We have more specific information about the administration error. The patient took the drug twice a day instead of once a day as instructed. So that's why this term would be much too vague. So if I would look for extra dose and administered, here we are again, go to browser. Here we are, PT extra dose administered. So this term should be used when an extra dose is administered once or only sporadically, not regularly. An extra dose that is administered regularly represents a deviation from the administration schedule. So again, be fully clear about the concepts that are available in MedDRA. So this really represents a schedule issue. So let us again look for the inappropriate schedule. Inappropriate schedule of drug administration. Go to browser. So here we are in the PT, and then now let's look. The patient took his drug twice a day and not just once a day. So scheduled daily dosing taken more frequently would be the correct assignment here. Or once daily dose taken more frequently. Here, once daily dose taken more frequently, even more specific. This would be the best term to choose from. Increased dose administered was another option. Increase dose administered. Go to browser. Here we are. Same PT. This would be incorrect because the single dose was not increased by the patient. He did take the drug twice a day and did not increase the single dose. Remember the concept description of dose. Dose refers to a single dose that is taken by the patient. And coding to LLT incorrect drug administration duration is unsuitable as well because nothing was wrong with the overall duration of the treatment. The patient took the drug for 2 weeks as prescribed and did not deviate from the prescription in this regard, but he took it instead of once daily, twice daily. And now the product leaflet confusion. We have the product confusion errors and issues. Here is the HLT. So product label confusion, here we are. And here you find patient instructions for use in label confusing, product leaflet instructions confusion. But this was not reported. These terms do not reflect what has been reported in our case. The patient didn't read the instructions thoroughly. It was not reported that the instructions themselves were confusing. So we don't know why he did not take, maybe he didn't have time and just read it very, very quickly and just overlooked something. So that's not due to a label issue. It was on the patient side that the patient did not read the instructions correctly.
So Caroline, we've got a question which relates to this one. If all you know is that the recommended dose is 10 milligrams per day and the patient takes 15 milligrams, so the label says that the overdose is 200 milligrams. So we know it's not an overdose, but all we know is they've taken 15 instead of 10. It doesn't say whether it's in one dose or two doses or a single dose. What would you do then?
I would say it's an increased dose administered. If it's, I would assume that it's an increased dose.
Thank you. That's what I advise. Thank you.
Yeah.
I'm happy that we're aligned on that one. Thank you. Thank you, Caroline. Carry on because the questions are very specific.
Yep. So this is again the hierarchy of the terms in the quiz. So extra dose administered would be incorrect because an extra dose was taken regularly each day in our case, not just once. And that is why an appropriate term under PT, inappropriate schedule of product administration, should be selected. And here, once daily dose taken more frequently would be the most specific term that we can find. Incorrect product administration duration would be inappropriate, any LLT underneath, because the duration of the treatment was correct. The single dose was not increased by the patient. He took the correct dose, but twice a day. And LLTs under product administration error would be much too vague. So, and here the product leaflet instructions confusion, again, this does not reflect what has been reported. The patient didn't read the instructions thoroughly, so it was not reported that the instructions themselves were confusing. And so the final suggestion is to select once daily dose taken more frequently under PT, inappropriate schedule of product administration. Just interrupt me, Jane, if there are questions to address.
No,
Otherwise,
Caroline, I think carry on because they're very specific.
Next one. Patient took more than the prescribed dose to get a better drug effect. So let's again look at the verbatim and answer the relevant questions. Is it reported whether it was accidental or intentional? Yes, we know that the patient consciously decided to take more than the recommended dose to get a better drug effect. Do we know who caused it? Yes, it was a decision of the patient. And was it in the framework of therapeutic use? Yes, it was. And we also know the stage where the error occurred. It was, we know that it was administered, but no contributing factor again was reported. So how would you approach this one now? Patient took more than the prescribed dose to get a better drug effect. Which LRT would you select? Unapproved dose administered, intentional overdose, increased dose administered, intentional misuse by dose change, or incorrect dosage administered. Remember our decision chart? What do we know here? Let's see what you're going for. Intentional misuse by dose change is by far the most popular answer here, but we also have the intentional overdose, increased dose administered, or unapproved dose administered as options. Let me close the poll. So thank you for joining and use our decision chart again. Here we have a different scenario. We know that it was intentional. We know that it was caused by the patient. And we know that it was for a therapeutic purpose. He wanted to have a better drug effect, meaning that this verbatim describes an intentional drug misuse. Here we are. So this is the classification. And now we will have to look for the appropriate term, misuse term that we can find in MedDRA in order to capture the full information of what has been reported here. So let me first collapse all, because otherwise it gets too busy here. Let's look again under injury poisoning and procedural complications. And now we will look into HLGT off-label uses and intentional product misuses use issues. And here we have the HLT for intentional product misuses. Intentional device misuse, drug delivery system, intentional product misuse. Here we are, intentional misuse by dose change, dosing frequency, product use duration. So the most specific term that we can find is intentional misuse by dose change. So we capture the fact that something was changed in terms of the dose that was taken, that was administered, and it was an intentional decision by the patient. So the other options that we had was intentional overdose. You will find it in HLGT overdoses and underdoses NEC under HLT intentional overdoses NEC. So here we are. Intentional overdose. But our verbatim alone does not allow for classification as an intentional overdose. More information about the drug and the labeled dose range would be needed to do so. And all other options that were offered in the quiz were incorrect. In unapproved dose administered, increased dose administered, and incorrect dosage administered do not represent intentional drug misuse, but drug administration errors or use issues. So that's why you always have to have in mind this decision chart in order to have the correct path for the classification, and then look into the terminology in order to find the most appropriate LLT that you can find. So here we are. Again, screenshots of the MedDRA browser showing the LLTs of the quiz. Product use issue would of course be incorrect, much too vague. Incorrect dosage administered. Dosage refers to the dose, schedule, and duration of treatment, so that's not correct. Increased dose administered, again not correct, because it does not represent a drug misuse by the patient. Here we have the correct LLT assignment, intentional misuse by dose change, and intentional overdose would also not be correct because we don't know whether this actually represented an overdose. We don't know the dose range. We don't know the exact dose that was taken by the patient. So here is the final suggestion for coding this verbatim. We would code to LLT intentional misuse by dose change under PT intentional product misuse. Next exercise. Doctor prescribed drug A off-label to suppress preterm labor after careful risk-benefit assessment. So what does this verbatim tell us? What do we know? We know whether it was accidental or intentional. Yes, we know that this was a conscious decision. Do we know who caused it? Who made this decision? Yes, it was the doctor, the HCP. Was it in the framework of therapeutic use of the product? Yes, it was. We also know the stage where the issue occurred. Yes, at the stage of prescribing, the drug was prescribed off-label for a patient suffering preterm labor, but again, no contributing factor was mentioned. So again, your turn. How would you code this scenario? Doctor prescribed drug A off-label for suppression of preterm labor after careful risk-benefit assessment. Drug use for unapproved indication, drug prescribing error, drug prescribed for unapproved indication, off-label use in unapproved indication, intentional use for unlabeled indication. Think about our decision chart, look at the verbatim, and make your choice. Exactly. Off-label use in unapproved indication. Drug prescribed for unapproved indication, that could be an error. So it doesn't tell that it is a conscious decision. Drug use for unapproved indication is also very vague. And intentional use for unlabeled indication could also be a decision by the patient. So we have to capture the full information of our verbatim, and that's why off-label use in unapproved indication is the correct assignment here. So let's use our decision chart again for this scenario. We know it was a conscious decision. It was made after careful risk-benefit assessment. We also know that this decision was made by a healthcare professional, here the doctor, and we know it was made for therapeutic purpose. So this incident can be classified as an off-label use based on our 3 criteria. And because we are also provided with the information that the doctor prescribed the drug off-label, we can select a suitable term under PT off-label use. So let me again show you in the browser. So here we have the HLT off-label uses under HLGT off-label uses and intentional product misuses and use issues. Here we are. And there's only 2 PTs underneath, off-label use and off-label use of device. If I open the off-label use, you see the specific LLTs that are available here. So off-label use, unapproved age group, route of administration, unapproved sex, use duration, fractional dose administered, dosing frequency. We have an unapproved indication. So LLT off-label use in unapproved indication would be the correct assignment. All the others would have been incorrect. Drug use for unapproved indication, you see, is considered product use in unapproved indication a very vague term. It's grouped under medication errors, product use errors, and issues NEC. And then the drug prescribing error. So it was not an error, it was a conscious decision of the HCP to prescribe the drug for an unapproved indication. So drug prescribed for unapproved indication would also not be correct. Product prescribing issue, you see the hierarchy here. We know it was an intentional decision for medical purposes by the doctor, so product prescribing issue would be much too vague. Intentional use for unlabeled indication would also be too vague because this is just an intentional deviation, but it could also be caused by, or decided to by a patient. Off-label use in unapproved indication is the most specific term that we can find because it, per definition, it tells us it was a conscious decision by the HCP for therapeutic purposes. So it was an off-label use, and we know that it was an unapproved indication. So that's the most specific term that we can find in MedDRA for the reported scenario. Here we are. Off-label use and unapproved indication under PT off-label use. Let me stop here again. Jane, other questions? Not too specific, just related to the
If I
demonstration.
generalize the specific question, we have one where the patient buys the drug, we know the patient's bought a drug, and we know that it's being used for a therapeutic indication, but it's outside of the label. We don't know if it was done in error or if it was done deliberately. What do you do then?
It's a use issue then.
To use this issue.
Yeah.
Okay, thank you. And then
Yeah.
we've got one here. If the doctor prescribed, but it was not reported if the drug was used, here in your example, it was prescribed, but we don't know that it was used. It's the definition of use again, Carol Ann, if you can
Yeah.
just.
Use is off-label use does not mean that it was actually then administered. So it's a more vague term, but it's the only term that we have off-label use. So off-label use in unapproved indication. So all the examples that we have in the companion document and in the PTC document always provide this instruction, so that we really should use the off-label use independent of the fact whether it was finally taken by the patient. But you would, of course, assume that if a doctor decides to provide a medication off-label to a patient for a given indication, that this is explained to the patient and that it is then actually taken. That's why we don't have specific terms for the administration of an off-label use in unapproved indication. Okay?
Yes, that's everything. That's all the questions we've had. Thank you,
Yeah.
Carol Ann.
And this is the last one. Doctor mixed up the drug names because they look similar and prescribed the wrong medication. So what can we take from this one? Do we know whether this was accidental or intentional? Yes, we know that it was accidental. Do we know who caused it? Yes, it was the doctor. And was it in the context of therapeutic use? Yes, it was. We also know the stage where the error occurred. It was a prescribing stage. And was there a contributing factor that has to be captured? Yes, a contributing factor was reported in this instance. So we will have to capture the full information. Doctor mixed up the drug names because they look similar and prescribed the wrong medication. What would you do with this one? Wrong drug administered, wrong drug prescribed, wrong drug, product confusion, drug name look-alike, drug prescription issue. Let's see what you're going for. Wrong drug prescribed, drug name look-alike. Yeah, these are the favorite answers here, and this is completely correct. Let me close the poll and again use our decision chart. We know that it occurred unintentionally. We also know that it was caused by the doctor, and we know that this happened in the framework of therapeutic use, so a medication error. And now let me again switch screens here. So let me search for wrong drug in this instance. Wrong drug dispensed. Here it is, wrong drug prescribed. Go to browser. Here we are, product prescribing error is the PT. So we capture the fact that it is an accidental incident, so that the wrong drug was prescribed accidentally. So this is a perfect combination term for what has been reported in this case. Now, what about the contributing factor? Again, let's look into the confusion, errors, and issues. And here we have the product name confusion, and we have device name confusion, drug name confusion, drug name look-alike, or drug name sound alike. What was reported in our case was that the drug names looked alike, and this caused the fact that the doctor prescribed the wrong medication. So drug name look-alike would perfectly capture the contributing factor in this regard, in this case. So all others are too vague. Wrong drug administered. We don't know whether it was finally administered. Product confusion would be too vague. Drug name look-alike is the most specific term that we can find to capture the contributing factor. Wrong drug prescribed perfectly captures the accidental nature of this event, and drug prescription issue is a vague term that you can choose when it's not clear whether something occurred accidentally or intentionally. So here we are. So the correct code assignments would be wrong drug prescribed under product prescribing error, and the contributing factor needs to be captured as well, drug name look-alike under PT product name confusion. Do we have questions, Jane?
No more questions, Caroline.
Okay, so this is a summary of what we have addressed today, and some relevant links that you can use to our website, the email address of our help desk, then the links to the browsers that the MSSO offers, and here the new web-based browser and the legacy web-based browser. The training schedule where you can find the training offers of the MSSO, and again, link to the MedDRA support documentation where you can find the points to consider documents. What I would like to make you aware of is that we have launched a learning management system beginning of this year. It's the latest addition to our training offerings. It provides a controlled environment for self-learning videos and guides users through a predefined learning path. There is a beginner and also an advanced level that you can choose from, and also there is a certificate and non-certificate track that you can select. And important to know, the number of accounts per organization is unlimited. Here are a few topics that are covered in LMS: overview of MedDRA coding and analysis, outcomes, suicide, social circumstances, pregnancy, interactive MedDRA coding. Also medication errors are addressed as a topic in this LMS system. So if you want to have more examples, more explanations, then please visit our, or log in our LMS system. So here is the way to log in, either with this QR code or with this link to a MedDRA LMS. What It's also important, what I would like to show you, if you click on contact on the MedDRA website, it's always useful to look at our YouTube channel. If you are not familiar with that already, let me go to the MedDRA website. Here, contact. Here is the icon to access our YouTube channel. And here you will find recorded sessions of all of our trainers, different languages, Chinese, Korean, Russian, Spanish, Portuguese, and some of the trainers also so in Spanish, in of in English, of course, there are trainings for medication errors. So you may want to visit one of the recorded sessions of another trainer, because everybody has a different style of presenting our webinars. So that's one option. And I've talked about the what's Let's Code Together. Let's Code Together. You see it's available in Chinese as well. It's available in Russian, in Spanish, and these are the ones that Jane and I provide. So if you have verbatims that you would like to address with us, but provided that it's really of relevance, of interest for a wider user community, just send it to the help desk, and we may consider this to address during our Let's Code Together sessions. So that was all for today. Let me switch back to my presentation. Here we are. And I hope that you have found this webinar helpful for your work, and hope to meet you again in one of our other MSSO webinars or face-to-face trainings in the future. Thank you very much for joining us today, and also big thank you to you, Jane, for your great support. I know that there's always a lot of questions in this webinar especially. So enjoy the rest of your day. A warm goodbye to you all. Bye-bye.
Thank you, Caroline. Thank you, everyone, for your feedback. Bye-bye. Bye-bye.